Good morning everyone. I'm Dr. Smily Sharma and I'm going to present a case of a 21-year-old female who initially presented to an outside hospital with complaints of left-sided chest pain for 3 months and breathlessness for 3 days. Her chest radiograph was interpreted as massive left pleural effusion. However, the attempt for pleural tap was not fruitful. Ultrasound chest showed a solid cystic mass and she was diagnosed to have lung malignancy and was referred to AIMS Jodhpur for further management. This is the CT scanogram where we can see opaque left hemithorax with the mild mediastinal shift towards the right side. The left main bronchus is seen traversing through the opaque hemithorax with air bronchogram seen in the left mid-lung zone. There is no presence of any calcification or cavitation. On careful evaluation, we are able to see that there was erosion present in the inferior border of the left rib. All these findings can be present in various intrathoracic malignancies, for example lung, in plural, as well as chest wall malignancies. She underwent CCT thorax which showed a heterogeneous mass occupying almost whole of the left hemithorax with multiple cystic areas present within. The mass was showing invasion into the mediastinum with engulfment of the mediastinal vasculature. There was invasion into the pleura with focal invasion into the extrapleural fat space. There was also invasion of the left hemidiaphragm. The underlying lung showed collapse. These are window images where we were able to see that there was no bronchial cutoff. There was no presence of any lesions in the contralateral lung. On careful inspection, we also found that the mass was seen extending through the neural foramina into the spinal canal. There was collapse of the D3 vertebral body with associated soft tissue component. No presence of any mediastinal lymphadenopathy was seen in our case. There was erosion of the left rib on the inferior aspect as was seen on the CT scanogram. The patient also, where we could see that the mass had heterogeneous T2 hyperintense signal with multiple cystic areas. The presence of the intraspinal component of the mass was confirmed with the MRI. On the MRI further helped us to delineate multiple bony metastasis which was not very well appreciated on the CT scan. Considering the diagnosis of a heterogeneous mass with multiple cystic areas showing multi-compartmental invasion and presence of bony metastasis, a provisional diagnosis of Ewing sarcoma was kept with a differential diagnosis of pleuropulmonary blastoma. The role of radiologist is very important in such cases in the establishment of diagnosis as well as in establishing the extent of the disease. The patient underwent ultrasound guided biopsy in our institution under proper aseptic precautions. The final histology turned out to be the Ewing sarcoma primitive neuroectodermal tumor as was evident with the presence of blue round cell tumors showing positivity on vimentin and CD99. The patient was kept on a neoadjuvant chemotherapy and was further planned for surgery. However, she expired while being on chemotherapy due to complications. In our department, we inserted a chemo port and helped to deliver the chemotherapy to the patient. The role of radiologist in such cases is also to look for the presence of any residual recurrent tumor and effect of chemotherapy once the patient undergoes treatment. Ewing sarcoma, now considering the discussion, Ewing sarcoma is a rare malignant round cell tumor which can present as a large aggressive masses in the chest wall and they have associated small pleural effusions, not the massive pleural effusion which was as assessed in the earlier institution. They can present with distant metastasis at presentation. They have an overall poor survival rate at poor prognosis. The learning points from our case is that PNET is an important mimic of lung malignancy and should be included in the differential diagnosis of a complex intrathoracic mass with spinal extension, particularly in children and young adults. A multidisciplinary team is required for the management of such tumors, where radiologists play a very important role in the diagnosis, in evaluation of the extent, in the location of the distant metastasis, performing image-guided biopsy, inserting chemoport and delivering chemotherapy, and assessing the response to the treatment. Thank you very much.
Hi Smiley, just I have one question. Whether any relation with the rib or the vertebra, because that is the most common site in the thoracic cage or skin tumors, what we call it, regarding the PNET's origin, or it was entirely intrathoracic?
No sir, we as mentioned that there was vertebral collapse, there was associated soft tissue component, there was extension into the spinal canal. So we gave the probable origin from mainly the vertebra and with extension into the thorax.